We are on live.
Yeah.
Good evening, everyone. Welcome back to one more session of Pure Urology. So today we have been able to get in touch with one of renowned urodynamic specialists of India, Dr. Mayank sir. I think he will be enlightening us regarding the basic needs of doing a urodynamic study at the basic setup, how to interpret these methods. So today we are having urodynamic study, how to do the basics machine and interpretation by Dr. Mayank Mohan Agarwal from India. So Mayank sir, before going into the details, so I would
Yeah.
like to introduce Mayank sir with a few words. So Dr. Mayank Agarwal has completed his urology training from JIPMER, Chandigarh, India, in 2005. In addition, he holds a National Gold Medal for Urology awarded by NBE, an awarded fellowship. He visited, worked, and Star Wars like Mellon Memorial Sloan Kettering Cancer Institute, University of California, Los Angeles, Wake Forest University, and USA from 2009 to 2010. During his tenure, he is an assistant or associate professor in JIPMER. He authored around 85 research articles in international peer-reviewed journals, chapters in urology books, and he has written a manual for urodynamic based on his years of clinical and research expertise in this field. So in this field of LUT dysfunction, he has introduced novel concepts in flow volume nomograms and the flow volume index in uroflowmetry. So he repopularized the micturition urethral pressure polyphotometry, discovered a novel pattern in detrusor contractions in patients with pelvic floor dysfunction, and affirmed the superiority of gabapentin over pregabalin in CPPS. A novel continent cutaneous urinary diversion employed by JIPMER pouch is accredited to his team. He is an editorial association with BMC Urology, current bladder dysfunction reports, and he has been awarded the top reviewer for Golden Urology Journal in 2016. He has also been invited for several national and international society for delivering lectures, and he has around 22 years of extensive clinical expertise in advanced urology laparoscopy, uro-oncology, female urology, kidney transplant, uroendocrinology, and laser surgeries. So he's currently now working as an assistant director of urology in Medanta Hospital, Lucknow, UP, Delhi, in India. So before I hand over to Mayank sir, so few basic introductory details I would say. So what made you to choose urology, sir?
Urology. Okay.
Yeah.
So my life has been like from the childhood, I wanted to be a doctor because there were many, you can say there were many doctors in our family, not my parents or brother, but many other people. So they inspired me. And as I joined MBBS and as the anatomy dissection started, I knew I want to be
Okay.
a surgeon. And
Okay.
somehow, when I chose surgery, I faced resistance, obviously, from the family. Ki, Bhaiya, why are you getting into trouble of being a surgeon? Why don't you get radiology? Because that was a hot branch at that time. But anyway, so once I joined surgery, had exposure to GI, urology, and all those branches. So I realized that urology gives you a very good abdominal surgery exposure, which a surgical candidate seeks that thing,
Okay.
and it is not as morbid as a fecal or biliary emergencies and morbidity.
I agree with
So
that.
balancing both the things, because my first
Okay.
choice was GI surgery, but soon I realized that GI surgery is going to be a mess. So I joined urology, you
Opted
can
for
say. I mean,
urology.
I'm being very honest, but yeah, that's the reason.
Yeah, that's true. Basically,
I think a lot of us
many.
take for this reason that we want to not leave abdominal surgery, but we don't want to get into mess of fecal and biliary
Yeah,
peritonitis
yeah,
and
yeah,
morbidity.
yeah. Right, sir. That.
Yeah.
So, whom do you give credit as a mentor for your training into urology, sir?
Um, it's a very good question and very difficult one. So, mentor doesn't have to be a very senior person. Mentor is somebody from whom you learn.
Yeah, agree.
So I can say during PGI days among faculty, Professor Mandal and Professor S.K. Singh as a PG as well as a young faculty, they have been extremely supportive at all stages. So once we
Mhm.
developed laparoscopy in our department, Dr. Singh was like a pillar who was standing
Mhm.
behind. When
Mhm.
I remember when I did my first laparoscopic radical nephrectomy,
Mhm. Mhm.
so he was standing behind me and
Mhm.
encouraging me. So case went well, and there was no looking back after that. If you ask me,
Super.
my colleagues, so two names definitely come up immediately. One is Chandra Mohan, who was immediately senior, I mean, 6 months senior to me. And
Okay.
I remember
Mhm.
as a chief resident and otherwise also, we used to discuss so extensively. I learned from him. So when you're planning a procedure, how to plan a
Mhm.
procedure. So I remember
Okay.
we used
Uh-huh.
to plan the radical cystectomy a day prior, right from the
Mhm.
skin incision.
Mhm. Mhm.
So he would tell me, so Mayank, we'll make a skin incision. Now this vein will come. We'll have to coagulate it. This is how we go exactly in the
Mhm.
midline. This is how we
Mhm.
not get into peritoneum. Just make a prepubic space.
Mhm.
And
Mhm.
to this date, whenever I do a radical cystectomy, lap or open or whatever, I always when I'm doing with my younger colleagues, I tell them,
Mhm.
ki,
Mhm.
देखो, you have to cut the peritoneum over the bladder 1 centimeter, not in the
Mhm.
cul-de-sac, and that is how you
Mhm.
get into the right plane. And Chandramohan told me that. Then the other name
Right.
comes up, Dr. Pankaj Wadhwa, who was a
Mhm.
couple of years
Mhm.
senior to us, and I think Chandramohan
Yes.
also will
Yes.
agree
Yeah.
with
Yeah.
me
Yeah.
that he gave us a idea of how to not lose your clinical sense and how
Mhm.
to
Mhm.
respond to a clinical situation, not like panicky response. So these
Yes.
are
Yes.
the
Yes.
couple of people. And then,
Mhm.
urogynecology, there are few names like I give a lot of this thing to Dr. Shlomo Raz. I was there with him for some time as an observer,
Mhm.
and
Mhm.
he was such a
Mhm.
passionate person. Then
Mhm. Mhm.
many other names, Dr.
Nice.
Sandhu in MSKCC, and then many people. I mean, uh, uh, for everything. But this is how the routing started.
Yeah. Yeah. Yeah.
And
Nice. Sir.
even
Nice.
now,
Sir.
even from my students, I learn. So they are my mentors.
Mhm.
So,
True.
you learn one thing
Good.
every day, and that person who teaches you becomes your mentor for that thing.
सही है सर सही है
Yeah.
Okay, so now let us go into your talk, sir. We'll
Yeah.
start with your presentation.
Just 1 second. Can you see
Yeah.
that?
Yes, sir. Yes, sir. Right.
So, good evening, everyone. I will. Sorry, the title is not correct. This talk is about how to plan a urodynamic study using a basic equipment. You don't have to have a very expensive imported machine. Whatever machine you have, what are the minimum requirements? How do you set it up? How do you do and how do you interpret? I will try to make it as simple as possible. Now, before we go to the how to do urodynamics, we have to refresh our memory to how the low inner tract functions. So during the filling phase, we know that the detrusor muscle remains relaxed and the internal and external sphincters, they remain contracted. And not only that, based due to the secondary reflexes, always remember the secondary reflexes. What happens as the contraction is the filling is increasing, the bladder is becoming more relaxed and the sphincters are becoming more contracted. Now this completes our phase, and it is under a very stringent neuronal control. In the voiding phase, a switch happens, which happens in the pontine maturation center. Now the extra sphincters relax, and very shortly after, the muscle starts to contract, and these secondary reflexes, they switch places. Now the excitatory bladder to urethra reflex becomes inhibitory, and the inhibitory urethra to bladder reflex becomes excitatory, meaning thereby that as the contraction of the bladder increases, the sphincters continue to relax, and as the sphincters are continuing to relax, the bladder continues to squeeze. So this is how a completion of voiding happens. So if we remember this basic physiology, not going into details of which nerve supplies what, if we can just know this, that this is the normal function of bladder and lower urinary tract, we can actually just go mechanically and understand the urodynamics. Now, coming from the size of room, a 10 by 10 or 10 by 12 feet is a bare minimum room for urodynamics without a fluoro. And we should have a ideally attached toilet to it. You will have a UDS cart, a printer cart, a urodynamic chair. You may have a simple chair or an expensive one, a cupboard, a wash basin area. Earlier, we had laser color printer in PGI Chandigarh and in other places like in Abu Dhabi. But now we have ink tank color cost-effective printer. Now, it is a very cheap color printer, which is ink tank and very easy to maintain. And the cost is also very less.
Thanks.
Coming to the video urodynamics room. Now, it has to be obviously bigger because it has to move around the fluoroscopic SIAM. So roughly at 15 by 15 feet is a bare minimum optimum size of the room with an attached toilet. These are the two examples. One from the left one is from MSKCC, where when I was there in 2009. And on the
Okay.
right side, this is the one from AIMS Rishikesh. So Dr. Sandhu
Oh.
and Dr. Ankur Mittal respectively have been kind enough to share these photographs. Now, you ideally for a fluoro machine, you should have a fluoro compatible motorized C-arm, which is made up of carbon
Okay.
fiber. If you don't have that much money, then that's fine. You can actually use a plastic chair. You can use a wooden chair. You can just apply your mind and get it made as per your requirement. You should have enough space for privacy. Curtains. There should be enough
Yeah.
number of plugs, ample UPS connections, because suddenly the light goes and your machine goes off without a UPS. So it will be a bad thing. Obviously, you should have a separate provision of clean drainage and sewage drainage. Now, if you don't have a video urodynamics, which most of us don't, and I believe that it is okay. So we can always plan for a separately done MCUG, VCUG in a radiology suite, because most of the big hospitals will have either a fluoroscopy machine, or you will have some coordination with some radiology center. It will be a more
Right, sir.
cost-effective thing. And another added advantage would be that it is a catheter-less voiding study, which you will have to corroborate with your urodynamics finding.
Right, sir.
Although it is inconvenient for the patient because you are doing 2 times studies, you will have to do cognitive fusion of 2 different voiding cycles, and you have to coordinate with another department. But I still feel that it is good enough. And as Dr. Paul Abrams also mentioned way in 2006 in his urodynamics book, that it is a very acceptable method of radiological correlation.
Right, sir.
So once we know about this basic setup, what do we want to know in a urodynamics? Now we want to know essentially pressures and sensations in bladder, how these pressures and urinary leak relate to each other, how these pressures relate to flow, like uroflowmetry with pressure studies. Then pressure in the urethra, EMG, and fluoroscopy come next. I will not be talking about pressures in the urethra because that would make it a little more cumbersome to understand, not too much in one go.
Okay,
EMG
sir.
activity, I'll just give in passing because it is generally, in my experience, not a very useful study because very difficult to maintain and interpret EMG. But if you can do it properly and afford the fragility of EMG probes and all, then it can be a good supplement.
Okay, sir.
We have to understand that what are we interested in? We are interested in bladder, basically pressure, detrusor, and urine flow. Essentially, that's what we want to know. But
Yeah.
as we know that pressure in the bladder is sum of detrusor as well as abdominal pressure. So, gives rise to a pressure called P vesicle. So there is no direct way to measure P detrusor. That is why we need a rectal measurement of pressure, which corroborates most closely with the pressure of abdomen on the bladder. So
Yeah.
this subtraction gives you a real-time P detruser while you're doing the study. That is why we actually need urethral as well as rectal pressures. Now, either you can go, I'll be talking about water-filled system mostly, because 90+% people will be using water-filled system.
Waterfall.
There is
Right, sir.
something called as air charge catheter system, which is very rarely used. I have not purposefully put it in this thing because it's not useful for most of us. It's an
Okay.
expensive system. It has its own positives and negatives. So if you have time, we can, verbally discuss later.
Yes, sir. Right.
So either we can use a cystometry catheter, which is a 2 lumen catheter, mostly 6 French is recommended, and a rectal catheter, which has a balloon at the tip and a slit inside on the balloon. These are the ones which I'm showing are basically company provided, proprietary.
Yes, sir.
They're
Yeah.
expensive. Ideally, they're
Mm.
single use, but obviously it becomes very unaffordable. So we can always re-sterilize them under using the
Mm.
guidelines of single-use device re-sterilization protocol, or
Mm.
we can go for infant feeding tubes. Now,
Okay.
one limitation, one would feel that if I use two infant feeding tubes, so let's say if I'm using two 5 French infant feeding tubes, one for filling and one for pressure measurement, so I'm giving a
Mm.
10 French obstruction in the urethra. So it is not
Yes.
so. So on the right side, you
Mm.
can see two circles which are 5 French each, for example.
Yes,
So
sir.
it is not this case. So they're not 10 French. Actually, if you
Mm.
distribute these two 5 French, so they come out to be equivalent to a 7 French catheter. Moreover,
Okay.
if you remove one catheter during the voiding study, the filling catheter, so you have
Mm.
only 5 French obstruction. So you can
Right,
easily
sir.
use infant feeding tube. These are cheap. You can use and throw. Don't have to re-sterilize. So I will
Mm.
recommend
Mm.
strongly for a peripheral place where the cost inhibitive things is there. Because if you don't clean the single-use device properly, like a cystometric catheter, it is a
Yes.
sure shot infection. So better to use infant
Understood.
feeding
Mm.
tubes.
Mm.
Similarly, for rectal, instead of using proprietary, because it is very difficult to, very cumbersome to wash it, clean it, re-sterilize it. So rather than that, you can just use 8 to 9 or 10 French infant feeding tube. Just cut the
Mm.
index finger or whatever finger of a regular balloon,
Glass. Mm.
and then oh sorry, glove finger,
Mm. Mm.
apply it so that the tip is close to the tip of that glove finger, and then fix it with the
Mm.
tape. Then make a
Mm.
small
Mm.
cut in the so make a small cut in the proximal part of that balloon of that finger. Now, why do you make a
Okay.
cut?
Yes.
Actually, why the balloon is required in rectum is because if you don't put a balloon, so then the fecal matter may actually clog the pressure measurement holes. So
Okay.
that balloon
Okay.
will
Mm.
safeguard the holes against that. And why do we need a cut? We may or may not use a cut. I prefer always to use a cut because we need just a water film around the catheter so that it is not stuck with the fecal matter. If I don't
Okay.
put this
Okay.
cut, what will happen? If I fill too much, the pressure will rise in that area, and that will
Mm-hmm. Mm-hmm.
falsely show in the P abdominal recordings.
Okay. Uh-huh.
In this way, you can, whatever extra pressure, it will just seep out through this hole.
Right, sir. Mm.
Okay, so now this is a typical cystometry curve. You will typically see four graphs. One is P vesical, that is a total
Mm.
bladder pressure. One is P abdominal,
Mm.
that is a rectal pressure. Then P detrusor, it is computed by the software in real
Mm.
time.
Mm.
And then lastly, a flow that is Q ura, the flow rate
Yeah.
when the uroflowmeter will be activated.
Mm.
One word about EMG activity. We what we use is kinesiological EMG, that is frequency and amplitude. Although
Mm.
most accurate would have been in needle electrode, which would go directly into the sphincter. But obviously, it is a very painful process, expensive,
Yeah.
and
Mm.
putting a
Mm.
needle inside the sphincter may lead into sphincter spasm. So, what is
Yes.
more
Mm.
commonly used is a surface electrode. We should remember that
Right.
if we are using EMG and using surface electrodes, we should always clean the perianal area of any extra hair, keep it dry,
Okay.
and use the ECG electrodes like this.
Right, sir.
Now, coming to pressure transducers. Various type of pressure transducers are available, and they can be single use, they can be reusable. Even if the single use, if you can sterilize it properly, you can use it for n number of times. So now with so much of competition, you don't have to spend lakhs of rupees for each reusable transducer. Now it is always remember, this connecting catheter is a critical device, because whatever fluid is inside this channel will go into the next patient, right?
Okay.
So if you don't clean it properly, it is again a sure shot thing for infection. So
Right, sir.
ideally, it should be sterilized. At least high level disinfection should be there. Anything less than that is unethical, and it's a guarantee for post procedure infection.
Right, sir.
Similar. Now coming to insertion of catheter. So now we have talked about, we are just talking about now paraphernalia only. So urethral catheter insertion is a critical, urethral catheter is a critical device, means it is
Yeah.
going into sterile cavity. So it has to be sterile. So we should not forget this paint, drape, jelly, sterile catheter insertion process. I have seen people doing it all the hanky panky stuff while putting the urethral catheter, and patient getting into sepsis after that. So don't forget it. Rectal catheter also is a semi-critical device. It has to be clean. It may not be sterile, but it has to be clean. You don't want to put the previous patient's shit into the next patient. So remember, none of this is non-critical. So have to be respectful. And this is the most important step where infection is there after the urodynamic study. When we say, so when many people will counsel the patient for urodynamics, you can get infection after the study. Until now, in last 4.5 years, we've had 2 cases of infection, both of which we could find the cause. One patient was a paraplegic. His urine culture was positive. It was done under antibiotic cover. The second patient was in retention. His urine culture was positive. It was done for BPH. In all, we don't give oral antibiotics, IV antibiotics, unless really clinically indicated. We don't give any antibiotic after the procedure unless it's really indicated. So antibiotics are not to be banked upon for this procedure.
But
Now coming to
you are giving the single shot
no,
injections.
no. So what I've started to do is, most of the cases I will put 500 milligrams of amica or 80 milligrams of genta in the fluid.
Okay.
No oral, no IV, before or after.
Okay, sir. Right.
So patient goes home without antibiotic. Patient does not get obviously, if a patient is on catheter, so we will ask the patient to change the catheter, get a urine culture, give 24-hour cover, then do the study for
Right,
bacteriuria.
sir. Right, sir.
Patient has active infection, we have to treat the infection, obviously. But
Right.
we don't send the patient on 5 days of septum or 5 days of unnecessary antibiotics.
Right, sir. But
So
you'll
coming
make
back
sure
to
that the culture is negative before starting the study.
either culture negative,
All the
or if the
they are
culture is
on
positive,
antibiotics.
we have to ensure that it is not infection, it is asymptomatic bacteriuria. We cover for 24 hours. That is it.
Right, sir. Right, sir.
Yeah. Now, coming to the machine. Now, you may have a Nexum Pro, which comes in lakhs of rupees, or you may have even Advent Urology or a Centron system or anything in between. But there are some criteria which machines need to fulfill, which I'll come to. That if that machine fulfill that, then basic urodynamics you can easily go. You can go through it. So you have a machine, then you have this pump. Can you see my arrow?
Yes, sir.
Then
Right.
you have transducers, and you have a computing processor. Now, this pump will be connected to the tubing. There is a special pump tubing which will be connected to the pump, and this pump is controlled by the software. So you know how much fluid it is pumping out.
Yeah.
Then catheters, you have minimum, you have 2 transducers, one for bladder, one for rectum. In this, I'm showing 3 because I'm mostly doing UPP along. So you can actually ignore it. Then comes EMG. So
Mm.
you do peripheral, you do two perianal electrodes and one neutralizing the neutral electrode, and these are
Okay.
connected to the EMG, and these are going to the computer for analysis. Then during Euroflow, you have this Euroflowmeter which is connected directly to the computer. So you
Oh,
have two transducer, 3, 4, and 5. Now, this is
right, sir.
the a complete urodynamics which you would ideally do, in which you have EMG, you have basic bladder pressures, you have urethral
Mhm.
pressures, you have rate of infusion, volume of infusion, voided volume, and flow volume. Out of
Mhm.
this,
Mhm.
you may actually get away with EMG, you may get away with urethral pressure, and you may have these pressures and a flow rate. And you will
Right.
have some one more line which I have not shown in this, which will show how much fluid is going in or out.
Yeah. So basically,
Now,
these
the
four or five are the one which is available in the basic machine
pardon?
or most of the
Yes,
machines.
yes, yes, yes.
What we have is
All
these five
machines,
lines. Yeah.
all machines will have at least 5 lines.
Yeah.
One will be P vesicle, P abdomen, P detrusor, which is computed, then
Yeah.
flow rate, and then bladder volume.
Volume. Yes,
So
sir.
five
Right.
things will always be there. So if your machine doesn't provide these 5 things, don't buy that machine.
Yeah.
Now, essential requirement, these are the ICS requirements. So
Mhm.
the accuracy should be about plus minus 1 centimeter of water for pressures. You should have range of minus 30 to 250 centimeters of water. You should have a frequency of around 3 hertz at least. That means three pressure measurements per second. If that much
Mhm. Mhm.
frequency with which the machine is able to calculate the each moment, so then it is okay.
Mhm. Okay.
So
Okay.
then equipment must have that facility to re-referencing of pressures during the study. Let's say
Mhm.
our machine has a thing called P det to 0, or
Mhm.
P abdomen to 0, or P vesicle to 0. That means if you have to make minor adjustments during the study, your machine software should be able to allow it.
Okay.
Now, filling volume, you should have a range of around 1000 ml. You should have a rate of infusion up to at least 100 ml per minute. And the sample rate of volume measurement should be at least 2 seconds, 2 per second or more.
Okay. Mhm.
Most of the current machines allow you self calibration. That means you don't have to calibrate them, but it's a good practice to check whether it's properly calibrated every now and then.
Mhm.
Although ICS says that it's preferred to check every 10 cases, it is difficult, and mostly it is not required because these are auto calibrable machine. But at the same time, it's very easy.
Mhm.
What you can do is you just fill a feeding tube like this on shown in the right side of the diagram. Fill
Yeah.
it, just take it up by 50 centimeters.
Mhm.
Measuring by the scale. You should see a
Mhm.
50 centimeter movement in the in your pressure measurement.
Gauze.
So that is a
Okay.
calibration. For Euroflow, you just flow. I mean, let the water go inside the Euroflow meter at a certain speed and a fixed volume, and you should see that your Euroflow is showing the same volume in total. So that is calibration of the Euroflow.
Right, sir.
Now, setting up for a study, you have to maintain sterility, and this is the first thing. Those who want to learn urodynamics, please maintain sterility. Please maintain
Mhm.
privacy of the patient, and it is a good practice to talk, communicate, and talk with the patient all along the study. Remember, just imagine a patient who has so much catheters here and there. There are people around, and you are talking. You are giving a dry, like unpassionate instructions. The patient, and you say the patient to stay mentally relaxed. How the patient will be mentally relaxed? You have to keep talking to the patient, isn't it? That discomfort
Yes.
has to go by talking, because you cannot let it you cannot make it
Mhm.
go just like
Mhm.
by saying. Place and fix catheter properly. Shave genitals and perineum with trimmer. I don't recommend to use blade because that can cause injury. Maintain sterility. Place balloon into rectum and not in the anus. Okay.
Mhm. Mhm. Mhm.
Fix catheter properly as shown in the diagrams, because
Mhm.
it is not uncommon that during the study the catheter has come out and the whole study gets wasted You have to reposition the patient to supine, replace the catheters and all. So fix the catheters as close to the orifice as possible.
Right.
Now flushing and zeroing. First step is flushing. So you flush through the transducer into the organ. On the right side, you can see that green, the PDET going up and the PDET going down. So in the first instance, we have flushed the P vesicle, and in the second instance, we have flushed the P abdomen. Once you have done that, you position it, zero it to atmosphere. The catheter, the transducer should be at the level of pubic symphysis upper border. And then you cut off the organ through the three-way catheter, and then you zero it. On the right side, you can see that it has become zero. So initially, the P vesicle and P abdomen were in negative, and once I did that, the zero all button, so all three have become zero now.
Okay.
Now you turn on the organ and cut off from the atmosphere. And now you can see on the right graph, there is some basic pressure in P ves and P abdomen, which is a physiological abdominal pressure. P det is zero. And on making the patient cough, there is no deflection in the P det. So that means a nicely calibrated study. Now you are all set to start. Now, once we have started, what is the patient position? Supine, sitting, or standing? Typically, the studies are done in sitting position. Now, there might be exceptions. Supine for patients who are quadriplegic. We want to just know the bladder compliance. Standing, if the patient is not able to pass urine in the sitting position. Typically, we will start the study when the patient is sitting position. What is the fill rate? Generally, the fill rate is about 10% of the functional bladder capacity. Now, how do we know functional bladder capacity? Either we already have some patient's bladder diary or at least couple of uroflow meters. So we will have an idea of this thing. The other way is if you don't have any of these, so you should not fill at the rate more than patient's weight divided by 4. I generally don't follow this. I will follow the 10% of functional bladder capacity. If I don't have any baseline, I will start the filling rate at 30 ml per minute and increase or decrease based on the how the studies goes on.
Right.
Now, as per the ICS, there are some parameters. Initial resting pressure, which is the P vesicle and P abdominal pressure at the beginning of cystometry. That is the baseline pressures in the abdomen. Then the first sensation of filling, that moment when you perceive that your bladder is not empty anymore. First desire to void, which is often called as normal desire. So a normal desire or first desire to void means that you would want to go to washroom if the washroom is easily available. Otherwise, you can wait. Then strong desire to void. That means not causing any pain, but you would want to search for a toilet. But so that means it is somewhat difficult to control. You want to empty yourself out. So earlier concept of typically that MMS machine has urgency and systometric capacity. We don't go for systometric capacity. Systometric capacity is that you cannot fill anymore. The patient is already in pain. Patient may have had overfilled bladder. So the voiding phase is going to be jeopardized. And if the patient normally also will not hold the urine more than strong desire to void. So it is irrelevant to fill the bladder anymore beyond that. Urgency is anyway pathological sensation or finding. So urgency is not as such marked in a normal urodynamic study unless you have urgency.
Right, sir.
For example, there are some these are loose definitions, not very not very well researched. So generally, if the first sensation comes between 100 to 200, we call it normal. If the capacity is something like 300 to 500, we call it normal. The bladder compliance, that is the last filling pressure dividing the total bladder capacity. If this value is more than 20, it is considered to be normal. Although there are a lot of individual variation in women, in neurogenic bladder patients and all. But in general, if your compliance is less than 20, it should alert a red flag. It should be a red flag for you. If the compliance is less than 10, it is a very high risk for upper tract damage. So you should be careful in low compliance situation. High compliance generally doesn't have any clinical implication much.
Okay.
Now, coming to the phenomena which happened during the study, you may encounter overactivity. These are the abnormal elevations in the P detrusor during the study. As you can see in the upper graph, there are low level detrusor contractions throughout this study. These are
Yeah.
phasic detrusor contractions. Or you may have a very phasic but very high amplitude overactivity. So that is first is whether overactivity is present or not. Now, overactivity can be phasic, that is during the study, or it can be terminal. That means it happens towards the end of the study when the patient cannot any longer hold and he just passes the whole urine.
Okay.
Then there is a term called compound detrusor overactivity, which means that after every overactivity, the pressure does not come back to a baseline. It just keeps on increasing after every overactivity. You also want to know whether the patient leaks with this overactivity, like the lower patient is leaking.
Yeah.
Coming to compliance, which I already mentioned, the upper graph shows normal compliance. That means the patient is, you have filled the bladder to, let's say, 400, 500, but there is hardly any elevation of P detrusor, even towards the
Yes.
end of the study. In contrast, you have a lower graph in which during the filling, the pressure keeps on increasing continuously. You can see that green graph, it shows poor compliance. So let's say towards the end, the pressure is 55 and the filling is about 300. So compliance is merely 6 only. So it is a very low compliance bladder. Remember one thing, whenever you have any patient with poor compliance like this, always stop the flow for 2 minutes and see whether the P detrusor is falling or not. If the P detrusor is falling, it means that the part of that poor compliance is because of increased tone of detrusor muscle, not because of only fibrosis of the bladder wall. And you should always mention that in your report. So let's say it increased to up to 55, but when we stopped for 2 minutes, it actually reduced to about 45. So there is a good 20% improvement in the compliance.
Right.
Now, if you're a person who's doing EMG, so in a well-done EMG, in a normal person, you will see what is called as guarding reflex. You can see the upper graphs. Slowly, the EMG activity is increasing throughout the filling phase in all these three. Now, what is it due to? I told about the secondary reflexes. So, as the bladder is distending, what is happening? The sphincter tone is also increasing, which is representing as increased EMG activity. So, if you have this during the filling phase, it means your reflexes are fine and the patient has a normal guarding reflex.
Right.
Or you may have this kind of situation, a well calibrated EMG. If you find this, so that means the guarding reflex is gone. The EMG activity is abnormally. I am sorry, I have to take this call. Can I just pause for like
Sure,
few
sure, sure.
seconds?
Yes, sir. No problem.
Oh, it's okay. The call went off.
Yeah.
So that means this the lower three graphs are showing that there is something wrong, whether neurologically or functionally, which is causing these kind of activities, like in patients of Fowler syndrome, like in patients of neurogenic bladder, like traumatic paraplegia, like in patients of dysfunctional voiders. Then you have some leak point pressure. That's another phenomenon you should mention.
Yeah.
There are two types of leak point pressure. Understand it very carefully. One is called abdominal leak point pressure, which is done only for patients in whom we are suspecting stress urinary incontinence, not for any other patient. So you ask the patient to cough, first light cough, then more cough, then more cough, graded cough, or you ask the patient to do a Valsalva maneuver, like blowing into a balloon or blowing out with the mouth and nose closed. So what will happen at certain point, the patient will leak urine, and that pressure will give you the leak point pressure, abdominal leak point pressure. That is done only for SUI. Then you have another thing called as detrusor leak point pressure. Now that's a very interesting phenomenon, and I think detrusor term is misnomer because This is a leak of urine which happens typically in patients with low compliance, that the bladder is filling under high pressure because of low compliance, and at certain point this urine starts leaking. During this point, there should be no active detrusor contraction. So it is a
Okay.
marker. If you have a low DLPP, that means that the patient has leaked just when the pressure reached 20 or less. It's a very safe situation. Upper tracts will not get damaged. Whatever extra pressure, it will leak out. If the patient does not leak during a low compliance, or if the patient has leak point pressure more than 40, it means that there is a very high pressure and it is going to cause damage to the upper tract. So you have to flag it as a red alert.
Right.
Now, coming to pressure flow study. There are two aims of a pressure flow study, and that's it. Two aims are, one is how much potential a particular detrusor have, like how much contraction can a detrusor do, whether there is an obstruction or not an obstruction. Number one. Number two, you want to know how much of the resistance is there to the flow. You understand? So that means these are only two aims. Is the bladder functioning properly? And number two is there an outlet obstruction? Correct? There are only
Yes.
two things you want to know from a pressure flow study. Now,
Right.
how you want to know is the whole game, how people have done researches over decades together. And this is how we are going to interpret it in my next slides. So we typically have three types of interpretations. A normal pressure, normal flow, which denotes that there is no obstruction.
Yeah.
We have a high pressure, low flow, which denotes that there is an obstruction to the flow. And then there is a low pressure, low flow, which denotes that the bladder does not have much power. However, there may or may not be an obstruction. So always remember, low pressure, low flow does not mean that there is no obstruction. It just means that the bladder does not have power to pump properly. Now we don't know whether there is an obstruction or not. Okay. Now, how do
Right.
we define what is normal pressure, what is high pressure? Now come to it. So there is no one, if you go by, just how much PDAT is high, if you go by saying PDAT 60 is high, or PDAT 40 is high, or PDAT 20 is high, it is like saying, uh, uh, it is like saying somebody's weight, it's like saying somebody's obese based on the person's weight. Now, you know that a patient's weight as a relation to his height is the criteria for calling obesity, isn't it?
Yes.
You cannot call a 6 feet 5, 80 kg man obese man, right?
Right.
So same thing goes for these things. Only pressure cannot tell you. Extremes are okay, but a routine pressure cannot tell you whether it's high or not high. You have to corroborate it with the flow. So for this in men, there are two parameters already well established. One is called BOOI. It is based on Abrams and Griffith's landmark study. And it is defined as period Qmax minus 2 times Qmax. Very simple. You have both the parameters, you just have to calculate. And actually, most of the machines will give you this calculation already.
Yeah.
So it just tells you how much detrusor has to function against a resistance. Now, the second parameter is detrusor contractility index. As the name suggests, how much potential does the detrusor actually have? So it is defined by period Qmax plus 5 times Qmax. Now, in men, you are well defined studies. How about women? In women, till recently, there was nothing much. But some years back, Greenwell and Solomon published a very nice article, and they independently found that even in women, much like AG in men, you have bladder outlet obstruction index, which tells you the resistance of flow by the formula of period Qmax minus 2.2 times Qmax, practically same as BOI of men.
Right.
For detrusor contractility index, there is much debate because there is no standard. This thing, some people would say a young woman would have similar DCI as a young man. For elderly, it may be as low as period Qmax plus Qmax. So we'll not go into a lot of details into women's UBS like this. So let us go by one first parameter. first clinical condition called bladder neck obstruction or prostatic obstruction. What will happen? You will have resistance in the flow, and because of which you will have high pressure in the bladder. Now, that high pressure does not mean that the bladder function has improved. No, it is just that that pressure is not releasing as flow. That is why you are seeing it as pressure.
All right.
So, what you will see a high P detrusor. You will see a low flow rate. You will see a bell-shaped detrusor curve. I will come to the importance of the bell shape. The shape of the detrusor curve is important in understanding the pathology of the obstruction.
Okay.
And you will also see how much urine is left inside. It is called voiding efficiency. Now, in this patient, you have a pediatric Qmax of 62. Now, how do you know whether it's high or not? You will see the Qmax is 8 only. Now, what happened? If you've done EMG, you will find relaxation in the sphincter. So at least you know the reflexes are fine. So that means there is nothing wrong with the external sphincter.
Yes.
And your pressure flow relations show that your AG number is 45. And in this case, your bladder contractility index is around 102. So any bladder contractility index more than 100 is considered normal.
Okay.
And any BOOI more than 40 means obstruction. 20 to 40 means equivocal, and less than 20 means no obstruction. So in this case, you have AG number of 45 means it's clearly obstructed.
Yes.
You can see even in these ICS nomogram on the right side and Schaefer nomogram on the left side. I think we need another topic to study this in details. But
Yes.
all in all, you have that period Qmax and Qmax point of voiding lying in the obstructed range means it's an outlet obstruction. Now, coming to when it is not in the outlet obstruction range, then how to rule out obstruction, like in detrusor underactivity cases. So, what will happen in a patient with sphincteric dysfunction? Now, this sphincteric dysfunction is a very interesting topic, and if you can understand this doing a urodynamic study, you have really taken care of a lot of patients, young up to middle age, who come with actually this problem and get unnecessary TURPs or dilatations or whatever. Now, what happens in this pelvic floor dysfunction or sphincter dysfunction is that the external sphincter is not able to relax properly during voiding. Now, what happens when it is not relaxing properly? It is inhibiting the detrusor activity using the secondary reflexes. So, the secondary reflexes are confused. They are not letting the detrusor contract to its full potential because the sphincter is not relaxing. Now, remember, this thing does not happen in bladder neck obstruction or prostatic obstruction. It happens only in external sphincter obstruction. Just remember a situation. If you're peeing and suddenly you have to stop your urine from coming out because you have to rush to somewhere, what will happen? You will just squeeze your sphincter and the detrusor contraction will stop. Now, when this happens pathologically, it is called dysfunctional voiding.
Right.
Now, what happens? This is one discovery which we have made when I was in PGI along with my colleagues, that we observed that in these set of patients, when the detrusor starts to rise, as soon as the flow starts, the detrusor stops to grow further. It just flattens out. It is called plateau detrusor pattern. We have published it a couple of times, and we've made some nomograms also on this. So, you would have learned that it is difficult to diagnose dysfunctional voiding because this happens and that happens and blah not. You need UPP, you need video urodynamics, etc. But if you can observe this, I'm not saying that it is essential. It is 90% concordance is there, not 100%. But if you can find this phenomenon like plateau detrusor pattern during your voiding phase, and if the pressure is not gone high, it is not meeting criteria of a normal bladder function like DCI is less than 100, and typically the BOI is not 40, it is going low only. But if you can see this plateau pattern, you can almost 90% certainty you can say that it is a patient who has dysfunctional voiding, which means either pelvic floor or external sphincter is not relaxing properly.
Right, sir.
Now, you can see this was a more flat pattern. Then you can have this kind of crescendo, decrescendo type of pattern. The patient is like a wavy pattern, as if something is inhibiting the detrusor to contract. So it's able to contracting, but then it is not getting that feedback from the sphincter. Again, stopping like that.
Nice, sir. Right.
In EMG, you can corroborate it with increased EMG activity. And then, so typically these patients will fulfill the mathematical criteria of detrusor underactivity many times, but they have this obstruction. Now, many times what happens, the detrusor underactivity can happen even without sphincter dysfunction, like in patients of diabetic cystopathy, or
Yes.
many young patients, or chronic obstructive uropathy, which has ultimately led to increased chronic retention. And they sometimes you will find the bladder is squeezing not properly. But in
Right.
these patients, like in this case, you can see it is a bell-shaped pattern. It is not a it is not a it is not a plateau pattern.
Plateau.
So you can say that this has underactivity without at least sphincter dysfunction. Now, this patient may have prostatic obstruction. You don't know. So you will have to find another way to find where is the obstruction. So whenever you have underactivity, always strive to find whether there is a concomitant obstruction or not. So in a pressure flow study, you will it is valid. These detrusor contractility index and BOI or what and what not, they are valid only for voluntary voids, not for overactivity voids. Like in this case, you see, it looks like high head obstruction, isn't it? So this patient had very severe overactivity. We made him to do, and he started to leak also. But I made him, took an opportunity to teach him क्या नाम है detrusor, sorry, urge inhibition. So patient was doing urge inhibition throughout, and finally he was able to withstand and overcome this overactivity. But if you just look this graph, it shows obstruction. But I know that this is overactivity inhibition, not voluntary void. Now, this was the voluntary void of this patient. Can you see that? In EMG, the initial part, it is showing urge inhibition. The second part, he has actually voided with such a high flow and very low pressure, and with a relaxed sphincter. So, pressure flow analysis is valid only for voluntary initiated micturition. As per ICS, you record your interpretation like this: normal voiding function. So you have a pressure rise and flow rate within normal limits, being more or less directly after permission with little hesitancy, and patient voids to completion. Then you have bladder outflow obstruction, which is high pressure, low flow type, with or without hesitancy, with or without elevated post void residue. Now, to interpret it properly, we need help of formulae, plots, and clinical correlation. Same goes for detrusor underactivity, low pressure, low flow. These are ICS terminology, which I will encourage the people to report it like that. So either we have unsustained contractions or fading contractions with or without elevated PVR. Now, the cause of underactivity, we have to need help from plots, formulae, and clinical correlation. We have already discussed earlier.
Right.
So, just showing a small this the lower is our Cox proportional hazard model, which we created for diagnosis of sphincter dysfunction in men. So you have three parameters: bladder outlet obstruction. If the bladder outlet obstruction is less than 40, you give a number to this. The number is written here. Then period pattern, if you have a bell-shaped pattern or a plateau pattern. Then you have period max and period Q max difference. So just imagine, I'll just go back to this graph, let's say. In this case, period Q max is about this much. Sorry, let me go here. Yes. So period Q max and period max, this is it. So usually in a patient of sphincter, you will have a difference of less than 10, but that's not the only parameter. So we will take all these three parameters into consideration, and then we give it probability of having a sphincter dysfunction. So we found plateau detrusor pattern, increase EMG in absence of straining, and so okay, UPP you leave around, and BOI of less than 40, and less than 10 rise of period Qmax to Qmax, as a marker of sphincteric dysfunction. So even without having to do a video urodynamics, even without UPP, you may actually get a VCUG done separately. You can diagnose sphincteric dysfunction with a great accuracy.
Nice.
Sometimes patients are not able to pass urine during the study. So
Yeah.
you have to make sure you do all the maneuver possible. If the patient is sitting, you ask the patient to stand or even squat, because many patients cannot void in this thing. You ask the patient to relax completely. Do not ask the patient to void with straining, because that is not give you any answer. So you will not call it diffuser atonia. It is most likely situational inability to pass urine, and you will report as such. Like, see this graph. Will you call this diffuser atonia? Actually, this patient was not able to urinate. So patient tried hard and strained and passed some urine like that. So I will not call it atonic bladder, because calling it atonic bladder, it has to corroborate with clinical findings. Like, which patient will have atonic bladder? And basically, a meningomyelocele patient or a
Yeah.
spinal cord trauma patient who will not follow the commands and initiate a voluntary micturition, or a patient who has pelvic nerve damage, like after radical hysterectomy, APR, or a patient who has a very severe diabetic cystopathy. So you will, unless you have any clinical correlate, don't call it atonic bladder. You will just say patient was unable to urinate during the study. That's all.
Right.
I think I'll skip the graphs. So to conclude, in filling phase, you will mention four things. How are the bladder sensations?
Yeah.
Then you will mention whether there is detrusor overactivity. Then you will say what is the end fill P detrusor, what is the compliance. Then you will say leak point pressures if it is relevant in that particular scenario. Like for an SUI patient, abdominal leak point pressure, for a neurogenic bladder patient, or any other relevant patient, DLPP. In voiding phase, you will mention PDET Qmax, maximum PDET, and post void. So based on these, you will categorize the void as either high pressure, low flow, normal pressure, normal flow, low pressure, low flow, or inability to void. If you have done, if you can find out any, like if you have low pressure, low flow, but you have a detrusor of plateau pattern, you may suspect that it is suspected that the detrusor underactivity could be because of sphincteric dysfunction. So to correlate clinically, like that, you will answer.
Yeah.
And at the end, antibiotic stewardship is the call of the day. We all are doing good job surgically, very good job surgically, but at the same time, the severe multi-drug resistant and now even carbapenem resistant organisms are on the rise. We
Yes.
don't have much options with these. So my request is use antibiotic judiciously for as short duration as possible for surgical prophylaxis, typically not more than 24 hours. Don't use antibiotic just by just by your you can say by habit, that patient goes home on septum for 5 days or cefixime for 5 days. Always ask yourself before writing any single dose of antibiotic, and you will see that by all means you can reduce the amount of antibiotic usage by 80 to 90%. Thank you.
Right, sir. That was an excellent talk, I had to say. So you have concised it in such a short and easy understanding. I think anybody who wants to build up a setup for a urodynamic study, or if they have started recently and they want to know how to report and everything.
I hope that it helps. And I have a YouTube video on how to set up for urodynamics. If those who are interested can actually just visit my YouTube channel. It is called @Dr.Mayank.22. And you can actually search on Google and you'll find it. So that, I think that should be useful for the starters.
Definitely, sir. Definitely helpful. So now I don't know the trend. I have around weekly one patient with young, around 30 to 40-year-old male, coming with very poor flow, inability to empty completely. Graph is okay, not improving on the alpha blockers. They still keep on coming back with the same symptoms.
Yeah.
So I was suspecting maybe a dysfunctional voiding
habitual.
Or a bladder neck obstruction, which is less common, but maybe a differential diagnosis. But yeah, these are the patients. Actually, it's a group of patients whom we will find a lot of them are actually dysfunctional voiders.
Yes, sir. So I got out of 10, I got 3 patients to have a dysfunctional voiding. With just simple training like sitting and voiding, doing a double voiding and pelvic floor relaxation exercise, they improved without any medications. That was
Absolutely.
literally
A lot of
Dr.
patients
Price.
will do like that. Yes.
Yes.
So as a start, you have to teach the pelvic relaxation properly, which I'm sure you're doing it.
Yes.
Take care of their constipation. Encourage them to void either in standing or in squatting position if the knees allow them. And to start with, I start with the alpha blocker along with tizanidine.
Okay.
So tizanidine is a centrally acting muscle relaxant. So alternative agent is baclofen. In my experience, I'm actually compiling the data for last 7 years. I'm using tizanidine, not baclofen, and I think baclofen, the tizanidine is a somewhat better. Now, obviously, there is no much data. There is only one study on tizanidine in children with dysfunctional voiding. There is nothing in the adults. So I'm just collecting data for last 6, 7 years. So let's see what comes out of it. But
Sure,
yes,
sir.
you rightly said that pelvic relaxation is the key actually.
Yes, sir. Yes, sir. Rajendra, any questions? Rajendra?
Sir.
Any questions?
Yeah.
Rajendra?
No questions, sir. No questions.
Yeah.
That's okay. It's a a lot of dose for a talk anyway. So anyway, I mean, even if there is a question later on in your site, we can always get in touch back and
Yes.
we can always have a discussion.
Sure,
And Siddhalanga, thank you very much for
Thanks a lot,
inviting
sir.
me over. It
Thanks a
was
lot.
very nice.
Thank you for
Being
sharing your
associated
time.
with your urology.
Yes, sir.
And you're doing
Thanks
a
a lot.
really good work for spreading the knowledge to young and experienced urologists. Thank you very much. Thank
Thank
you.
you, sir. Thanks a lot.
Thank you.
Let us
Bye-bye.
catch up
Have a
once
good
again.
day. Bye.
Yes. Bye.